on integrated data for public health research. I'm James Stanley. I'm a biostatistician here on the Wellington campus. So today we've got a really interesting set of 3 talks on using Stats New Zealand's integrated data infrastructure, or IDI, for public health research. And today's presenters actually are all co-directors of the University of Otago Wellington's Integrated Data Group. For those of you who are at the Public Health Internal Research Day and were wondering what had happened to the Big Data Research Group, well, we changed our name to something that we thought sounded better. So today, the 3 speakers are going to talk to you about the importance and the utility of this kind of data analysis, and along with some applied examples of research using this work as well. So they'll be talking for about 10 minutes each, and there'll be time for questions at the end. So we'll sort of take all the questions at the very end. So I'm going to introduce each speaker as they get set up. As a preliminary note, Maddie White, who was going to be presenting today, can't be here today, so Neville Pierce is going to be presenting on her behalf instead. So to start off with, Dr. Sheree Gibb is going to be, who's a senior research fellow here and really the driving force behind using the IDI for health and social research here on the Wellington campus. She works on a lot of different projects in several teams, including the Better Start National Science Challenge using big data sets there, and really brings along a lot of methodological robustness to the work that we do here and across the country as well. And she's going to tell you about some of those methodological robustness issues now. So Sheree's going to give an introduction to using integrated data for public health research.
Thank you, James. Kia ora koutou. Good to see lots of people here. Okay, so as James said, I'm just going to give a brief introduction about what integrated data is and some of the pros and cons of using it for research. And then we have got 2 examples of integrated data research projects for you, one about pre-diabetes progression from Andrea Teng, and then one about housing first, which was meant to be Maddie White and now is going to be Neville Pierce. And then I'm just going to come back for a few minutes at the end and tell you about some resources that we have for researchers who are using integrated data in their work. So, $1 million question, what is integrated data? I think put at its simplest, it's when we take 2 or more separate data sets, so data sets that are collected separately and they have different information in them, and we combine them together into the one data set. So often we do that at the person level, so we're combining information about a person from different areas. But it can also be done at a household level or a family level or something like that. And a lot of you will be familiar with integrated health data. So New Zealand for a while now has had really high quality whole population health data, and it can all be linked together or integrated using National Health Index number. So that's things like hospital discharges, pharmaceutical data, maternity data, mortality, cancer registrations, all of that data can be combined together to give us really, really rich information about somebody's interactions with the health sector. And that's been a really fantastic resource for research. Many of you will have used it. We're not going to spend much time on that today because I think a lot of you know a bit about it already. What we're going to spend a bit more time on is this thing called the integrated data infrastructure. So who's heard of this before? Quite a few, or you probably wouldn't be here, right? Who's actually used it? A few people in the front row and a few others. Yep, all right. So what it is a collection of New Zealand government administrative and survey data, and there is actually some non-government data in there now as well, linked at the individual or person level. So a prototype of this was developed in 2011, it's relatively new, and health data was added to the IDI in 2013. And since then, interest in it from the health sector has really taken off. The really useful thing about IDI is it allows us to connect information about a person across different sectors. So for example, we can connect their health information to their justice information, or their health information to their education information. It's a huge database. It's quite complex. There's more than 550 tables, and they're all linked together through the central spine, which is essentially just a big list of all of the people that have ever lived since, the 1880s or something in New Zealand. And all the other data sets, the health and the income and the education and things, are all connected to this central spine. So why are people interested in the IDI? What does it give us as health researchers that we didn't have before? One of the biggest things, I think, is that it gives us access to a whole bunch of new data sources that were really difficult, or in the case of things like IR income data, impossible for university researchers to access previously. And what that lets us do is take a much broader view of health. So in addition to just looking at what happens in the health sector, we can look at things like housing and education and benefits and income and all those social determinants and social issues around health that we might be interested in but are hard to get from health information alone. Another thing that's really useful about it is that many of the data sets, just by their nature, have a longitudinal structure. So they sort of follow people over time, and you've got prescriptions over time or hospital admissions over time. And that allows for a lot of complex analysis and things, and causal type analyses. Most of the data sets are what I call whole population data, so population level data. They're not surveys, they are everybody in New Zealand who has used a particular service. And that's really good when we want to look at small populations or rare outcomes, so particular types of cancer. Suicide is a good one, that's quite a rare outcome. You simply can't do those things in a small survey because you just don't have the numbers that you need. And obviously when you've got this huge amount of data all linked together, there's a lot of issues around privacy and security and confidentiality, and we have to be really careful. One of the good things about the IDI, it's managed by Statistics New Zealand, and they are really experienced with these confidentiality and security issues. It's their bread and butter. So all of that stuff is taken care of by them. Researchers have a set of guidelines to follow. There's a lot of security requirements around it. You have to access it from a special little room with no windows where you sit all day wishing that you're outside. And they deal with issues around creating privacy impact assessments to link the data together. They do all the linking themselves. They deal with the raw data, and then all of the identifying information gets stripped before they give it to researchers. So I think for people like us, that's one real advantage of using the IDI, is that all these thorny issues are managed by an agency that has a lot of experience with that sort of thing. But it's not all smooth sailing. So there's a number of challenges that we've come across as we've started to use the IDI for research. It's really complex, as I said before. There's a lot of data in there, and the documentation is patchy. Some of it is good, some of it is awful, some of it is completely missing. So it can be really difficult to get started if you're not familiar with a lot of data in there, which you probably aren't. And it's a really steep learning curve, and it can take new researchers many, many months just to be able to get started, really. It's quite a big task. Expertise in using the different data sets is scattered across different researchers in the university. So some people have expertise with different types of health data. There's a few people around who know about ACC or benefits. There's people like myself who know about migration and income, but they're sort of in little pockets all over the place. And what ends up happening is researchers end up duplicating their efforts. So everybody wants to learn about tax data, and they're all sort of learning themselves. There's no central place where they can go to learn about stuff, except for the resources I'm going to show you at the end. Another issue is that the information, I say it has a lot of breadth but not depth. So there's a huge amount of information in there, covers a lot of different sectors, but it's not very rich. A lot of it's to do with service use and how government money is spent, but we don't have those really nice, rich, social information about families and relationships and well-being that we might want. And as I've mentioned previously, documentation is pretty patchy, so it can be quite hard to understand data quality issues and how to work around them to make the most of the IDI. So I'm going to come back at the end and tell you about some resources that can help you with some of those problems. But for now, we're going to move on to talking about different projects that have used integrated data. So I've just got a few examples up here of the recently completed or ongoing projects using data from the IDI. So Andrea completed a project about the Christchurch earthquake and cardiovascular events. There's a small project being done and a bigger one currently waiting for funding on tuberculosis risk in new migrants. We've got, with Ruth Cunningham, a project about pathways to first episode psychosis in Rangatahi Māori, the Māori youth. That's a really interesting one. And as part of Better Start National Science Challenge, I do a lot of work on childhood obesity prevalence and trends in that and correlates and things. And then we're also starting to get into some methodological research. So one project we've done a little pilot project with Amanda Kalsvig, is about linkage bias in the IDI. So when all that data gets linked together, whether linking errors are more common in some groups of people than others, and whether that introduces bias into people's work. So I think we'll now move on to Andrea, who James is going to introduce, I think. And I'll be back at the end.
Thanks, Sheree, for that great introduction to using integrated data. So Dr. Andrea Teng is going to talk now about a particular applied project. So Andrea, for those of you who don't know her, is a senior research fellow in public health position. She's currently studying for her PhD on impacts of taxes on sugar-sweetened beverages in the Pacific Islands, which is not using integrated data. So you might say this is her spare time research here. So today, Andrea is going to talk about this work looking at progression from pre-diabetes to diabetes.
Kia ora koutou, ko Andrea Teng aho. Thank you, James, for introducing this work. So basically, I'm going to talk about this project. So it's in the IDI. This is funded by the National Science Challenge Healthier Lives project. And I want to acknowledge my co-authors. So I worked closely with another Healthier Lives project, He Picking a Waiora, and they were working with Māori communities to understand more about diabetes. And they came up with this question. So what is the progression of pre-diabetes to diabetes, and what are the protective factors that protect against that, particularly in regards to ethnicity they were interested in. So that's where this project came from. And why would we want to look at pre-diabetes? Just to give a little bit of a background on that. Pre-diabetes is an independent risk factor for cardiovascular disease and for death. Old data now, but roughly around a quarter of adults in New Zealand have pre-diabetes. And there's a concern about over-medicalisation. So if we treated everybody in that group with drugs, it's going to cost the country a lot. So there's a lot of interest in what we could do to prevent progression in this group. New Zealand progression rates of pre-diabetes weren't known before we did this project. And also, interestingly, a lot of the literature on pre-diabetes progression to diabetes is sort of from randomised control trials, and it's often using glucose tolerance tests and other measures. So there's very few studies that looked at HbA1c defined pre-diabetes, which is interesting because in New Zealand, that's how we define pre-diabetes and often how we detect diabetes, at least initially. And this is really important that we're looking at this because we know we've got increasing rates of obesity in New Zealand, and there's huge and stark ethnic inequalities in that, in diabetes as well. So it's really important when we're thinking about public health prevention pre-diabetes. So why would we want to use the IDI in this project? I guess it's possible we could have used the National Health Collection. We were funded to use the IDI, so that was the first step. The second reason, and the one we put in the paper, of course, is there's a lot of extra social variables in the IDI that made this study possible. We could look at a lot of different protective factors like income, census variables like te reo, Indigenous language, education as well. And also because it's a whole of government data set, as Sheree talked about, we're able to have information for all of our study population, and it's a longitudinal data set, so we're able to see how some of those factors changed over time. And also cardiovascular risk assessment is an assessment that adults of a certain age in New Zealand get to detect the risk of cardiovascular disease. And one of the tests is done as an HbA1c test, which means that routinely adults in New Zealand in these particular age groups are getting an HbA1c test. So in the PHO, where this study focuses, there was a 92% coverage of that particular assessment, which basically means we've got a lot of HbA1c test results that we can look at and how they've changed over time. So this is the data linkage. We're very pleased to be able to work with National Hauora Coalition. This is a PHO largely based in South Auckland and other parts of the North Island. There's roughly 130,000 people in the PHO, so it's actually quite small, but they were keen to provide their HbA1c test results over 8 years, and also they provided BMI measures on those individuals, but we only had BMI at the start of the follow-up for about a quarter of the people that had pre-diabetes. So this data was linked to the IDI, and that's a long process that took a year. It was new and it hadn't been done very much, and it was a nightmare. But basically there's an MOU that was put in place between National Hauora Coalition and Stats New Zealand. I'd be happy to talk to anyone who is thinking about doing something similar. Within the IDI, there's a lot of variables that we could look at, and I've listed those. The first step was to define the study population, often an important challenge when you're doing a project using the IDI. So for this one, we defined the study population as anyone in the PHO population that had a test result of HbA1c between 41 and 49 millimoles per mole. People were excluded if they'd had any HbA1c tests previously that were higher than that, which meant they're more in the diabetic range. And they're also excluded if they were on the VDR. So that's a algorithm to detect diabetes from health data sets. We weren't focused on women with pregnancies that had hypoglycemia. So if anyone had hypoglycemia in pregnancy, they were excluded from this population. And we only could include people if they had more than one HbA1c test. So they were followed up from the baseline to the subsequent most recent test. And diabetes was defined as 50 plus HbA1c. So this is a flow diagram of the linkage process and how many people sort of fell out along the way. And I think really helpful when you're doing linkage studies to present your results and think about your population in terms of a flow diagram. And it's actually one of the things that journals are asking for now from linked data studies. And doing this, Sheree was already able to see some of my questionable decisions about how I define my data sets. So I think it's very helpful for communicating that. So in this example, up here is the PHO data, and that was linked via NHI to the National Health Collections data in the IDI. The National Health Collections in the IDI is probabilistically linked to the IDI spine, which Sheree mentioned. So by that point, I lost about 300 of my PHO population of 14,000, so not too bad. And then on this population, I did the progression estimates, so from prediabetes to diabetes. But I needed, for the multivariate analysis, I needed complete information on income, education, and deprivation data. So by the time I got complete data on all those things, it was 9,222. Which is a lot of missing data from the original 14,000. And I explored how that affected my regression results, which I'll show you shortly. This is a broad summary of some of the key results. The cumulative incidence of diabetes after 3 years for this population was 5%, so about 1 in 20, which was actually less than we expected given the results we'd seen from other trials and other studies. The progression was greater in younger adults, it was greater in men, and it was, as we would expect, much higher in those with a higher HbA1c because they're closer to the threshold of diabetes. It was higher with those with the higher obesity, higher BMI. What was interesting is that progression was actually lower for people who spoke Te Reo, and that was independent of other socioeconomic factors. And it was also lower for people that were treated with metformin. And there was higher progression rates for Māori and Pacific, but when in the regressions, when we adjusted for HbA1c, those ethnic differences were much smaller, they went away. So sort of showing that maybe those ethnic differences about the time when people present and the level of HbA1c at the time of when they first get pre-diabetes. So if it's picked up later, it's more likely to progress faster. And this is the two different regressions, one run on the full complete data set on the left column, and then on the right column is the data set with complete data on every variable. So this is a Cox regression, so looking at the outcome of diabetes among this pre-diabetes population, adjusted for age, sex, ethnicity, and HbA1c. And just to look at some of the size of the differences between the coefficients. So on the full data set, you can see the ethnicity didn't make a whole lot of difference. So comparing Māori versus non-Māori, for example, very similar rates of progression. Whereas in the final, in the subset of data, that coefficient was a lot larger, or a little bit larger, similar confidence intervals. And we can also see the age results differed a little bit as well. I've put up the ones that differed the most on this slide. And also the education differed quite a bit as well, particularly around tertiary qualified people, and how protective that was. It appeared a lot more protective than it really was in the subset of data. Yeah, and just to show the language, the Te Reo results were statistically significant in both data sets. So what were the strengths and limitations of this work? Well, yep, we've talked a little about the longitudinal analysis, the breadth of social variables. Having these questions come from the community and from, I mean, Te Koha Health was particularly interested in things like Te Reo and how protective that was yeah, you know, an awesome addition to being able to use this data to help them with those questions. Some of the limitations in here, the major one being selection bias for two major reasons. One is the individuals had to be enrolled in a PHO and have at least 2 HbA1c tests to be included in this. So there's people that might not be enrolled and they will be missed out here. And also individuals with missing data that were missed out from that multivariate analysis. Missing data as it has an impact on the results as well. And limitations, clinical information. So we don't have a whole lot of detailed primary care clinical information in here. And so a lot of the previous studies have those variables. And also this is one PHO, so it's largely based in South Auckland, might not exactly apply to other parts of New Zealand. So in conclusion, I think what we've shown is that some of these risk factors could be used if we wanted to prioritise pre-diabetes interventions to the groups with the highest rates of progression. And also this is the first study that's been able to identify Indigenous language as a protective factor against diabetes, pre-diabetes progression. So I think there's a lot of scope for more research there. And yeah, if anyone wants to do it, go for it. And I can put you in touch with people. But yeah, the IDI opens up a whole lot of work that could be done looking at that, looking at language in Te Reo in New Zealand. Obviously really important and really, you know, interested in policy making circles as well. And of course, obesity being a key target for prevention was confirmed here. I'll put up my key IDI acknowledgements for all IDI studies. We'll have one of these slides. And if you want more information, there's the papers. Thank you.
Thanks, Andrea, for a really interesting talk. So to finish up, as I mentioned earlier, Maddie White can't be with us today to present. So Associate Professor Neville Pierce is going to be presenting on their project on her behalf. So those of you who don't know Neville, he's a biostatistician and co-director of Hei Kaianga Oranga, who do some really great housing and health work here in Wellington that has great impacts across the whole country. And so today Neville's going to be describing work on Housing First, which is a project looking at the impact of providing housing to homeless people as a priority step in improving their health and social outcomes.
Thank you very much, James. So I'm presenting for Maddie, who couldn't make it. I'd like to thank in particular Maddie, who most of this work it is, and Jenny Omber, who I work with on the Housing First programme, and the People's Project, who are our community partners and who've housed rough sleepers I'll be talking about. Kia ora katoa. I'd like you to cast your mind back to ancient history of 2014 through 2017, when National was in power and there was a focus on, there was a lot of media attention on homelessness and a lot of narratives around homelessness. And in particular, there was a narrative, and we got funding under a hard to reach group, that homeless are a hard to reach group. They don't interact with services much. They're hard to find, they shouldn't be there, and certainly things like the integrated data you wouldn't expect them to be showing up on. And that was part of the narrative, and we were putting in a grant to say, actually, maybe we could have a look at this. There's a lot of assumptions there. There was a narrative about homelessness being random, and homelessness could just happen to anybody. The homeless people are much like you and me, and it just happens out of random bad luck, circumstances. And then there was a narrative coming out of the community, or some of our partners, in particular the People's Project, that homelessness was a cause of exclusion and systems failure, that people were working in silos and that they weren't addressing that health, social services and things were seeing the people and not dealing with the underlying causes that were driving that people were in homelessness, and they weren't dealing with it. They were just dealing with their silos, and that they were excluding people, homeless people, from their things, making them apply again and again because they were hard and complex to deal with. So those are three quite different narratives, and they have quite different data interpretations. So I was very keen to have a look at, well, what's the truth and what can we do about this? Naturally, coming from public health point of view, and quite a lot of housing research, I have a suspicion that it was the systematic one that the community were saying was quite right. So I want to talk about Housing First and what they were doing in Hamilton first. And this is a model come out of the US where you take people who are rough sleeping or very high risk of rough sleeping, move them directly into permanent sustainable housing. You do the housing first, and then you do everything else, the wraparound services, mental health, dealing with all the issues that got them into homelessness. But there's no emergency housing, there's no transitional housing, there's no pathway of be good, there's no preconditions for housing. You just do housing first, hence the name. And the People's Project in Hamilton, who were really the first in the country to lead this out in any kind of scale. It was quite a brave step for them. And we worked with them to set up some very simple data sets, systems, so as we could have a look at how their interactions of their client base were going with health, to MSD, justice, IRD, and a few others, so as we could understand what the story from the government perspective and what the data set story of the people who were rough sleeping and now housed by the People's Project, what the story of this client base is at the time and in the future. So again, what's very important is the time frame here. The first person was housed in October 2014, and then the last person was housed in June 2017. So the People's Project housed everybody they could find who was rough sleeping in Hamilton, who came in the door. For everybody, they asked them their name, their date of birth. We got from those we were able to get the national health identifier that Sheree's talked about as being one of the linkers. We recorded the first date they went in the door, and then this is the date they were housed, because Housing First, the model here is that the magic happens when somebody's housed. And then we had some categorizations around homelessness that turned out to be pretty useless, actually, so I won't talk about them. So there we go. That's our scenario. We're looking at this. So it's a group of 390 people. Interestingly, against our preconceptions, the slight majority were female. Most people were working age. And of course, unfortunately, there's a vast overrepresentation amongst Maori. So that's the group. And here's what we found. So for a hard to reach group, we found 99.2% of them had health records that were accessible in there. That's more than you or me, or the ERP group is the estimated resident population who's in New Zealand at the time. So in fact, you were more likely to be linked if you were homeless. Justice, you were much more likely to be linked if you were in the homelessness group, much more likely to have numerous interactions with the justice system. And social development and tax, you were actually more likely to be coming on their radar if you were homeless, if you were rough sleeping in Hamilton. And the extent of the service usage, so then there's the question of seeing this big jump. Was it happening for a long time? Was it happening for 5 years beforehand? Or was it just this immediate period where they were homeless? Was there time for the services to be doing something about this? And we saw, so the difference is 5 years beforehand, you have over 3-fold in hospitalizations, a nearly 20-fold indicator in mental health, 20-fold difference in mental health, nearly over 10-fold difference in justice sector interactions. They were less likely to be earning wages and salaries, but only 1/3 as much, and much more likely to be in receipt of benefit in the previous 5 years. So a 5-year very significant difference that unsurprisingly in the year while they were housed is also very much replicated. Well, in the year before they were housed, so in the year that they were definitely homeless, there's a very similar high level of disparity here going through. And looking at the broader data set, actually this difference goes back 15 years. You could see that this group has elevated our interactions with government services for 15 years. Of the 390 people, they had 200,000 interaction with government service usage. So that's nearly 500 each. They were not particularly hard to reach. 5,000 interactions each, sorry. they were not hard to reach by any, or after the first 5,000 times, I guess it was tough. The most common single interaction was to be prescribed antidepressants, which talks about the medical system's answer to homelessness. The most common solution was a prescription for antidepressants. And that really talks about the silos that we work in and the silos that we need to be thinking of different solutions when people are coming in and presenting with homelessness, that depression is a cause and is a symptom, but the cause is homelessness is not helping the depression, and that needs to be dealt with. So where are we now? So this is just a baseline, but we've definitely answered some questions. We've shown that you can link this group. They're very easy to link and they're very visible in the data. They have an extremely high rate of service usage, and it does talk that we can identify these people, we can identify, and we need to prevent homelessness. We need to have systems that when people are coming in asking for help, do prevent homelessness. We also have this group who've been housed in since June 2017, and we're looking at the difference between housing rough sleepers in Hamilton and not housing rough sleepers in Auckland. So it's not a perfect randomized control trial, but it's a case control difference with some problems. And we want to have a look at some of the linkage bias and the problems that Sheree and Andrea pointed out that don't come across as much in this group, maybe because we didn't look as much, but they're obviously linking, and that was the key question. And we have, the linkage bias is only going to further expand the fact that these people are there and they're linkable. So they are definitely being able to found. Sheree.
Andrea, how do I get Okay, so just as we finish off, I just wanted to point you to some resources that we have available for researchers who are using integrated data. So I mentioned in the first section, and then Andrea and Neville both touched on the difficulties working with this kind of data. So some of you will have heard of the Virtual Health Information Network, and most of these resources have been developed through them. So Andrea and I teach an introductory IDI course through the Public Health Summer School here at Otago Wellington, and also through NZSSN, which is, meant to look it up, New Zealand's Social Statistics Network, is that what it is? Or Social Science Network, one or the other. It's a one-day course, and it's a theory-based course, so we don't use any actual data, but we give people an orientation to the IDI and what it is, and some of the kinds of problems you might encounter when you're using it, and just try and give them enough information that they can get started on their learning. We are also developing a new practical course, so a course that will use some actual data. It's not actual IDI data, it's synthetic data that we've made for the purpose of the training course, but it will be a computer-based course rather than a theory course in a classroom, so it'll be in a computer lab. We're hoping to run that for the first time ever in the upcoming Public Health Summer School in February. If you want more information about the courses, so we run them here in Wellington, we're also running them in Christchurch and in Auckland, and we've run one in Dunedin previously. Have a look at the Virtual Health Information Network website, which is up there. We have a page about courses, and it shows you the dates of all the courses and everything, and links to registration. Another initiative we've been running here at Wellington is e-carpentry workshops, which teach basic data science and data analysis skills. Some of you might have attended one that was on a few months ago. We're hoping to run other ones in the future. We usually send an email around staff, so have a look out for that. And so that's courses. We have a bunch of other resources on the Virtual Health Information Network website. So there's topic guides about different aspects of the IDI, like what is the sign and how do I find information about ethnicity, how do I find geographic information, a whole bunch of stuff on there. And there's also samples of code on that website as well. So I do encourage you to go to the website and have a look around and have a look at the resources that are on there. We run a monthly morning tea for IDI users here at the University of Otago Wellington, and also at Massey University in Wellington. I think most IDI users here are joined up to that, but if you are a user and you're not joined up and you want to be, just contact me or Andrea. We have an email address for the VHIN on the bottom right there, vhin@otago.ac.nz, where you can email if you have short questions, or you want some advice, or you want to be connected with someone who knows about the IDI or particular types of data. Send an email through there and we can connect you with the right people or answer your question. And if you want more contribution to a project, so it's not just a quick question, but you actually want someone to work on something, then Andrea and myself and some other members from the Integrated Data Research Group are available to contribute to projects if you've got FTE available to fund us. So that's for more substantial contributions rather than just a quick. We won't ask you for FTE for a quick couple of questions, but it's if you want us to actually work on the project. So the co-directors of that group, those of you who came to the strategy day would have already heard this from James. It's myself, Andrea, and Neville, who you've heard today, and James, who was introducing us all, and Ruth Cunningham, who's in the middle of the lecture theatre there. Yeah, so if you have a question, or you're interested in finding out more, or you want one of us to contribute to a project, or you just want to discuss it, please just send an email to one of us or to the VHIN email address, and we will get back to you. That's it. So I think we've got 10 minutes for questions.
Thanks, Sheree. And before we have questions, if we could just have a quick round of applause as a thank you for all the great speakers today. So yes, so we do have about 10 minutes for questions. We might have some online questions as well, which Brodie will be asking from the front here. But otherwise, I will come around, or Brodie will come around with a microphone in a second if people have questions they would like to ask for any of the speakers.
Great presentations, all.
I was just going to say, obviously know you, Amanda, but if you are asking a question, if you'd just like to introduce yourself quickly, say what your name is and where you're from, mainly for the benefit of the people at home or elsewhere. Thank you.
Okay, I'm Amanda Jones. I was going to say I'm from Canada, but I think you mean I'm from public health here. So great presentations. Also glad you arranged this seminar. I wonder if you can talk some more about linkage bias and how you might go exploring and understanding what that is, and if there are kind of like key considerations that are like generic across projects, or if it's like very tailored depending on the data sets that you're working with.
Yes, I will speak to that one. I had a slide about linkage bias, which I deleted this morning because I thought it was going to be over time, so I just undeleted it. Yeah, so when data gets linked up in IDI, there's two ways that it can go wrong. So you can miss a link that should be there, so two records don't get linked together when they should be, or you can link records for two different people together when they shouldn't be. So you can have a false link or a missed link. And if those types of linkage errors are not evenly distributed across the population, then it might cause bias. So at the moment, we don't have any information about, we don't have much information about the level of linkage error in the IDI, and we don't have any information about the bias that it might cause. So we have been, with Amanda Carlsberg, doing a little pilot project that was funded by Healthier Lives National Science Challenge, just to try and find out if we can get enough information out of IDI and the IDI team to find out something about linkage bias, or whether it's just a complete no-go. And the results of that pilot were quite promising. So we got some information, some useful information from them, and we'd like to progress it with kind of the eventual goal of making tools for researchers to correct for linkage bias in their work. So other than that, I probably can't answer a lot more at the moment because we don't really know anything about it. Andrea might want to come up to the microphone.
And just briefly to add to that, Amanda's work will be put into some sort of already, and a user guide that you can look at and the researchers can read, and we'll be putting that on the VHI website. So look out for that. Thank you.
Any other questions from the audience here?
Have we reached peak IDI at this point, or are there plans to add a lot more data in the medium to longer term?
As for whether we've reached peak IDI, I don't know, but I do like the phrase. There are definitely plans to add additional data. So big things that are going in the next wee while are the New Zealand Health Survey, which will be really useful. Oh, sorry, I'm not standing close enough to the mic. the New Zealand Health Survey will be added in the next wee while, I think by the end of this year, with the caveat that it will only be able to be linked to health data and not the other types of data in the IDI. Interai, which is an older people's health data set, is also being added. And they do have, I have seen a huge list of about 20 or 30 different data sets where they're in progress. At various stages of talking to people and making MOUs and doing the PIAs and stuff and getting it all lined up. So I do think we've hit a lot of the big data. Most of the big government data sets have already been added, but there still are places where we could expand. Another one that hasn't come up yet, and I'm surprised, is primary care data. So as a lot of you will know, primary care data is a big gap in health data because we don't have a national collection for it. There have been bits and pieces of primary care data added to the IDI, for example, the stuff that Andrea added for her project, and there was some mental health primary care information from ProCare added for another project. So I think that's probably the big untapped health stuff at the moment to be added. Whether it will happen anytime soon, I don't know. I'm a bit doubtful because it's quite messy and it requires a lot of legal and admin work to get it all sorted out. But it would be wonderful if they could. Yeah.
So a question from online. Someone says, do you have any idea of how the government uses the IDI? And are you aware of any health-related reports published by the government that uses the IDI?
So there's a lot of government use of the IDI. Andrea might be able to remember better than me. I think it's about half of projects come from government and half come from universities. Is that right? Yeah. If you go to the Stats New Zealand IDI website, you can search all of the approved IDI projects, so you can see for yourself if there's any relevant projects there. I don't know specifically of any health reports published by government, but I'm sure there will be some. I would go to the website and have a look at the projects, and often those projects have links to things that have been published from them.
Hi, have the IDI has been being used now for, I think, about 3 years. Have there been any problems, and is there going to be, how are they being dealt with, if so? And sorry, when I say problems, I mean problems in relation to use of data and confidentiality issues or whatever. And what kind of system do you think, or what kind of approach is going to be taken if there are problems?
Yeah, that's a good question. So it's been used for quite a while. It's in the health space a few years, but prior to that, there was a lot of government use in other areas. I have not heard of any major breaches. There certainly are minor, they update security and software things from time to time when they find some sort of vulnerability, but I don't know of any actual breach of data yet. I can't comment on what kind of approach will be taken when there is one. It would be a Stats New Zealand issue, and it would be for them to deal with. Yeah, I don't know. I mean, one thing that would help in that space is, I think we're perhaps not having enough conversations as a country about the privacy and the ethical issues around this. I mean, Stats is open about it. It's on their website and everything, but there hasn't been a lot of public debate about it, which makes me think that people perhaps aren't quite aware of what is there and how much information is all there. So it would be quite nice to have those conversations before we're in a crisis kind of situation rather than afterwards. But yeah, I don't see them happening at the moment.
Sheree, and the other presenters, thank you very much. It's a very impressive workload and way that you're operating it. My question is rather a selfish one. We've been trying to get hold of energy data for ages on the basis that if it's not on the IDI, we have to get individual consent from everyone and then from the companies. And of course, they're half state, half private, and they see it as their competitive advantage. But I've been working with people from ECA to try and get it on for a while. Can you tell me if there's any progress there? Because that's pretty critical in terms of social and economic determinants.
Off the top of my head, I don't know of any progress. I can look up the special list that I have for you if you like. I'll send it to you. I used to work with someone at Stats New Zealand who had the same problem, and it took years. They finally got a couple of, I can't remember if it was power companies or lines companies permission and got some data from them, but it didn't get put into the IDI. It was being used for something separate. But I can put you in touch with them as well if you'd like.
And one final question from online. Mustafa from the College of Education says, we're administering assessments and collecting information from a national representative Year 4 and Year 8 students. And he was wondering if we can link their data set with the IDI. They have student NSNs.
Yes, so one thing I didn't mention actually is that both the examples that we had today from Andrea and from Maddie and Neville were examples of projects where the researchers took a data set of their own and linked that to the IDI and then used all the other information in the IDI. You don't have to use the IDI like that. You can just use the enormous amount of information that's there, but it is possible to link up your own data set. So yes, in theory, if you've got a data set with national student numbers on it, it would be able to be linked. The issues are around permissions, so getting permissions from the data owners and lining all that up and doing the memorandums of understanding and the privacy impact assessment and everything with stats. And then also at the stats end around their workload. So they have been moving in the last couple of years to stricter rules around uploading your own data, I think because it's quite time consuming for them to upload everybody's little data sets. And they are moving towards only wanting to upload data if the data owner is prepared to share it with other people as well. So it's not just going to be used for one project. It will have, with permissions, obviously, will be able to be used more broadly. So I would encourage that person to email Stats New Zealand. You can find their microdata email address on their website and have a talk to them about it and see what's the likelihood that they would be able to upload their specific data set.
There are some sort of related personal consent issues as well for some data sources. So the New Zealand Health Survey is a good example where survey participants were explicitly asked for their consent to link through to their routine health data. So only those people who have consented to that can be linked, and they can only be linked to health data. That was how it was asked. So there's the other layers on different data sources. But that's all we have time for. So thank you very much, first of all, everyone, for attending online or in person. And if we just finish up with another thank you for the 3 speakers today for a great talk.